it's really a pleasure to come and talk to everybody today. You know, we often are asked to talk to other professionals, and it's just really nice to be able to talk to the patients because there's so much to be said and so much for us to be able to share with you. And as I was composing this talk, I realized, but I want to include that, but I can't include that. Oh, darn it, you know. So just call me. My number will be up there. Okay. So I don't know if I'm as tall as these guys, and I feel like it's in my face, so I'll do this. I'll be brave, like the 6'9" guy. Okay. So our rationale for treating a patient, you know, there's progressive disease that oftentimes is not responsive to responding to whatever therapy you're on. More aggressive neuroendocrine cancers will have a systemic option where you're taking a pill or an IV infusion, whereas some of the non-aggressive ones, or at least octreotide avid patients, will be getting their sandostatin. And I think you guys all have an understanding of that. But at some point you progress, and that's kind of where we jump in. And some of these therapies just aren't effective for you, and so we can jump in and treat those too. More significantly, that Dr. Salem was able to touch base on was the symptoms, the problems with the symptoms. We have patients who have disease outside of the liver, as an example, and they have a lot of symptoms. Really, patients, especially carcinoid patients, start to have carcinoid symptoms not from their primary, but because it went to the liver. The liver is the filtrating organ, and when the liver gets disease involvement, that's why you have your side effects. So that's why oftentimes we're sitting here talking about liver, because that's really the problem. That's where all your symptoms stem from. So it's nice that we have radioembolization, chemoembolization, and bland embolization in place to help some of those side effects. So we do think outside of the box. Most patients in most diseases other than your disease, we wouldn't necessarily think of giving them any sort of liver-directed therapy if they had disease outside of the liver, because then they need systemic treatment. But it's just such a unique disease that we're able to offer that for you and be able to offer symptom management of diarrhea and flushing, and if you're an insulinoma patient, controlling your sugars better. So it's just all very relevant to understand that, and it's a huge pain palliator for patients who have these really big, bulky tumors. So when you come to interventional radiology, it's kind of a scary time because there's all different kinds of diseases here, different problems here. You see inpatient and outpatient here. If you go to a surgery center or a surgery area, most of everybody you're going to see is walking in like you. But in IR, patients are being called down from an inpatient status, and they're sick and they have all these different problems. So it can be kind of intimidating. So some of the things that you might see done in interventional radiology are biopsies and chest ports. And today I'm going to touch base kind of on different ablation therapy, side effects management, and embolization. So ablation can be cryoablation, radiofrequency ablation, microwave ablation. And we don't just offer those to a liver. We can do kidney, we can do bone. As a matter of fact, bone ablation is very helpful for bone symptoms if a patient has specific bone symptoms. We can have a vertebral spinal lesion that can be causing problems for patients, and we can even put like a cement in there after we ablate it and help maintain its ability for a patient to still walk around. Because if you just ablate it, you kind of leave a hole, so you kind of have to fill that hole. Anyway, so there's a lot of different options with even ablation alone for solitary tumors that are persistently a problem. And then for embolization, Dr. Salem talked about the three main ones. Bland, meaning there's just no chemical component, it's just a particle that blocks flow. Chemo, meaning that there's chemotherapy attached to that gets placed inside, and then the blood flow is stopped, and then radioembolization. And so in preparing for this, I think a lot of this is kind of obvious. If you're preparing for a procedure, every facility has it differently. So for us, it's 6 hours before, no food, 2 hours before, no fluids, clear fluids only during that time frame. But other facilities might have it a little bit longer. If you're getting anesthesia, it's just nothing after midnight. That's sort of their rule. Every clinician also handles medications you're allowed to take differently as well. For us, when we're doing an angiogram, no matter which embolization procedure we're doing, we actually don't really have to take you off your blood thinners, but a lot of clinicians do require you to be bridged to Lovenox and then hold your Lovenox. Metformin glucophage, those type of medications, not glyburide, not that, but the other ones that are a glucophage component, they affect your kidney filtration and in terms of you being able to clear the contrast out. So if you're getting an angiogram of any sort and you're on glucophage, just be careful, talk to your clinician. We prefer that you hold glucophage the day of and the day after, and then you can resume there after that. For your blood pressure medications, your heart medications, please continue to take those, because if those are out of whack, then we can't do anything for you on the table. And in terms of your Sandostatin, if you're an octreotide avid patient, please know that we'd want you to keep your long-acting going, and we'll talk a little bit more about that right now. You'll continue your long-acting for those who have the somatostatin receptors. If you're not a somatostatin receptor, you're not on octreotide, then it's done. You don't need to worry about it. But what we do is anytime we treat a patient and have them on the table, we do prefer that we give you a short-acting in the room, even though you're on your long-acting. Because the peak to the short-acting is only 1 hour, so we give it to you when you're on the table. So right when we're doing it, we know that you're taken care of and you're not going to have a carcinoid crisis, which is an exacerbation of your flushing, diarrhea. You can get tachycardic. You can have problems from that. So if for the patients who are very tenuous and they do have breakthrough flushing, breakthrough diarrhea while they have their long-acting, and they're instructed at home to give themselves some medication, or if they're on a drip where they're having a constant infusion, those patients get an IV drip for us. And I just kind of included our little dosing down there. I believe you guys are all going to get these slides at the end, by the way. So you get placed into a room, we get you ready, put monitors on you. When you have an interventional radiology procedure that requires an embolization procedure, we do a groin approach. And if you're getting some ablation, it's always percutaneous through the skin. It has a special tipped needle, so we're able to just take care of it from there. The procedure time is basically 2 hours, 2 to 3 hours, a little bit longer for the ablation procedures because we have to place the needles properly. For the angiogram, whenever we're doing an angiogram, we try to use a closure device to the groin. It allows you to ambulate 2 hours later, which is really convenient so you can get home sooner. The only time we're really admitting people is for the bland embolization or the chemoembolization. We'll admit for a 23 observational stay afterwards, and we do that just because we want to be able to control your pain. It can be kind of rough on you. So immediate post, we're thinking about Zofran. Zofran is such a great drug. Hydration is super important. We make sure that you get your IV hydration. It's just that sedation medications cause patients to just feel nauseated, so we try to control that for you. Pain control is mainly for the bland embolization, chemoembolization, because you're blocking blood flow. So we want to monitor you, make sure you're under control. And then we just do site checks, no driving for a day, IV hydration, oral hydration once you get home, and monitoring you for carcinoid crisis as immediate post. For the radioembolization, we try to make sure everybody goes home on a proton pump inhibitor, which is your Prevacid, your Protonix, anything that's going to, you can have a Nexium already ordered for you. You just continue that for 10 days. Antibiotics are prevalent in the chemoembolization just because we blocked a little bit of the blood flow. We don't want any problems, so we just give you an antibiotic to go home with for a couple of days. And again, it's the same thing at home. You're monitoring for bleeding and infection. Your activity level is kind of resting for 3 days. And showering the next day is fine, but bathing not for 5. The side effects, we use the common terminology criteria for adverse events. We try to stay in line to be able to grade how you're feeling, so everybody speaks the same language. Medical oncologists use the same thing. So everybody has a better idea on how well you're doing when they say, oh, they were a grade 1 or a grade 2, because that's really significant that we understand that. So that being said, we had done a study specifically for our neuroendocrine. I believe Dr. Salem already touched base, and I think his nurses are always left interpreting the physician, so here we go. 63% were shown to have some level of fatigue, usually a grade 1 fatigue, and it usually lasts 10 to 12 days. It's because the radiation is highest in the first 3 days. Its half-life is 3 days. So at day 10 to 12, it's inert. The radiation level is inert. So It's some patients can get steroids. We just kind of shy away from that because there's nothing wrong with being tired. If you're tired, it's okay. Abdominal pain or discomfort is more for patients really who present with pain. For the bigger tumors, they have pain because usually really the only symptom these patients are having is bloating sensation, fullness sensation, kind of an ache, that really Tylenol is fine. Fevers and chills in 8% of the patients were because of the bulky tumors just dying off, and so that's why they have fevers and chills, and it's kind of just a normal response of your body getting rid of tissue. The nausea really had to do with the sedation medications, so that's why we implemented the IV hydration better and Zofran. Diarrhea, weight loss. If you're a carcinoid patient, you understand that you'll probably have diarrhea, you'll probably have some flushing if you're a symptomatic patient, but in the end, 7 to 10 days later, those symptoms should dissipate. As a matter of fact, in many of our patients, when those patients feel those symptoms come back, we know it's time to treat, no matter what the scan says. So we really pay attention to your symptoms. This is just a nice little graph to show chemoembolization versus radioembolization. This was a study to show the side effects, and really fatigue won out on Y90, the radioembolization, but all the other side effects were more prevalent in chemoembolization, just because the chemo can and will seep out systemically. Ablation is really kind of an easier procedure. Its side effect is to the location of the disease, and pain control is just for that site. So inspiration might be a problem. So just make sure that you keep an eye on the site itself for fever, pain. We'd want to hear if you have any complications from that, and Tylenol or ibuprofen is fine. I wanted to make sure you guys saw the some of the resources that I have. I see on here, I knew about the Wellness House. I actually did a lecture about 10 years ago, 12 years ago for them, and I forgot to include them on here, but I saw them walking around today with brochures, so please make sure that you grab one of those as well. And I'm done.